Good evening, everyone, and welcome to tonight's Goodfellow webinar on navigating RSV management. This is very topical heading into our winter months. My name is Dr. Hazel Fuyava. I'm a GP in South Auckland and I work for the Goodfellow Unit. Tonight we have Dr. Nikki Turner and Dr. Emma Best with us. Nikki is an academic general practitioner and medical director of the Immunisation Advisory Centre at the University of Auckland. Nikki's interests are immunisation, respiratory illness, primary and public health care. She lives in Wellington and works part-time as a GP. Emma is a paediatric infectious disease specialist at Starship Children's Health, Te Whatu Ora, and she's a senior lecturer at the Department of Paediatrics, Child and Youth Health, and a medical advisor at the Immunisation Advisory Centre in the University of Auckland. Her clinical and research areas of interest include vaccine preventable diseases, paediatric respiratory infections, and appropriate antimicrobial prescribing in children. The webinar tonight was commissioned and funded by GSK. This is a non-promotional webinar, and the content was produced independently by the speakers and the Goodfellow Unit for a New Zealand healthcare professional audience. So I'll now hand over to Emma and Nikki. Thank you.
So kia ora all. So I'm going to start off, and I'm going to focus on adult RSV and particularly adult vaccines, because actually they're very close on the horizon. So I'm going to do a bit of a whip through RSV and vaccines, and then hand over to Emma, who can really talk to you more about managing childhood RSV and options for childhood approaches and not just vaccines. So let me go for this. So firstly, I have no conflicts of interest except my cat Eric tends to help me with presentations. So this is any odd bits in this presentation, please blame Eric. Well, the disease, I think all of us are very familiar with RSV. It's in the usual milieu of respiratory illnesses we see a great deal of. So here's my little summary of the situation for RSV that we're all very familiar with. Your first exposure is usually in infancy, and we can get it repeatedly throughout our life. We know it's common and highly contagious. We know that we see it in the peaks of autumn and winter. For a lot of us, it's just a mild to moderate upper respiratory tract infection. And most of us by adulthood have reasonably good immunity. But, some people don't. And the burden of severe disease is really in the young kids and the very elderly, and as usual, people with comorbidities. And then the other important thing about childhood RSV is they are the source of infection. For all of us that have had young children, we know very well how easy it is for kids to spread their love and their bugs around all of us. Now, these are some quotes from some research done from my colleagues who worked with me on the Shivers 5 study, where some of you in Wellington may have been involved in this study, where we were doing point of care testing, where people coming in through winter last year, we were testing in some general practices and after hours for RSV, for COVID, and for flu A and flu B. And some really interesting reflections from people coming back about, when it turned RSV positive in the respiratory illness. So, GP feedback was he was quite surprised how many older people came in with RSV now that we were identifying it point of care, and quite sick with it. There's the comment in red of my childhood RSV, I would not send them to school or daycare. Having seen what it does to kids, it would just make that decision a lot fairer, because it's so ambiguous. That's when you don't know what the disease is, how sick my kid is, how infectious they are, and what's the consequences. A couple of other quotes here. I think it's kind of good to raise the awareness of these other viruses, because RSV, for a lot of people, can be not much, but for elderly or babies, it makes them very, very unwell. I think if people were more aware when they had RSV, they'd probably be more careful about being around babies and old people. And then the final one from a patient, obviously, if it came up with influenza, I would know what to look out for, but I wouldn't necessarily need to see a GP because I know that they can't really do anything for it. I'm not actually as clued up on treatment with RSV, but I figure it's similar to flu. So RSV is an illness that many people are unaware of, particularly in adulthood. And so being able to do point of care testing was hugely helpful in terms of making the diagnosis, and then people beginning to understand about the disease for themselves. So, what is the burden of disease in New Zealand? Well, of course, a lot of it is about how carefully you can monitor the disease, and it's different in many countries, but this is New Zealand data showing that of 4,600 hospitalizations for acute respiratory illness, about 7 to 8% of them are actually RSV. Medium length of stay is up to 4 days. There were some deaths, and there was a small percentage that actually ended up with very severe prolonged illness. And there is an estimation of the cost per event, which is quite significant. So RSV has a big burden of disease in New Zealand. Now, this is a bit more data from the same group of people, Nam Prasad and team, from the early Shivers data. And if you look at the imputed crude incident rates, if you look down at the right side there, you can see that the burden of disease in adulthood is particularly in those over 85, and it exponentially goes up in those, it's high in those over 65 and particularly high in the over 80s. So the highest incidence of RSV is in the over 80s. They've got a 30 times higher rate of hospitalization compared to adults over 50. Obviously, as we could all predict, immunocompromised respiratory symptoms make it worse. I've written down a list of risk factors there. To be honest, it's extremely similar to the risk factors for flu. These are respiratory illnesses that affect the elderly and affect people with important risk factors. And as we see with flu and every other respiratory illness, being of Māori or Pacific ethnicity background or living in areas of high depth makes you at high risk of severe disease. So very similar to the pattern for flu. Now, we all lived through this. You'll remember this, that the extraordinary experience we had in the New Zealand natural experiment with COVID when we shut the borders. The result of shutting the borders and having really strict social measures to stop the spread of respiratory illness is it didn't just work for COVID. We did not see flu for 2 years, and we did not see RSV for a year. Now, if you look at this graph, you can see that the blue line is just any severe acute respiratory illness hospitalized, and the red line is RSV. No RSV was in the New Zealand community in 2020. New Zealand opened the borders just to Australia, and a few weeks later, we had this huge surge of RSV, which is what you can see in 2021. It came on earlier, it was very sharp, and there was a lot of it. And I'm sure many people remembered out there. And you can see from the next year that we are now beginning to return to our usual winter peaks. So what is the virus? Well, here's a little picture of the virus. This is the little dude and what he looks like. There are 2 antigenic subtypes, RSV A and B, and they probably act fairly similar. The infection disrupts the respiratory immune response in the airways. And the severity and infectivity are directly related to the viral load. Now, because of this, I've got my things mixed up. Now, if you look at this RSV virion, the important thing about it is there are 2 major attachment proteins which facilitate the virus entry into the cell. They're called the G, the attachment glycoprotein, and the F, the fusion glycoprotein. They are the markers and they are the targets for vaccines. So RSV vaccines have been considered for a very long time, and the RSV target are these glycoproteins on the surface. The G targets ciliated airway cells, and the fusion F fuses with the cell membrane. Now, the target is the F protein. Now, there's an interesting background story to RSV vaccines, and I think we should all know a little bit of this, that there is a pre and a post-fusion form to the F. The original vaccine development back in the 1960s, the early vaccines, which were formalin activated, they created enhanced disease, and they actually, in the clinical trials, had huge amounts of people being admitted to hospital, and they had a couple of deaths. After that time, they realized that there were 2 different conformations for the F protein, the pre and the post fusion, and the early studies had been using the post fusion. Now, the problem with the post fusion form, so here's the picture of the virus, and you can see on the left with the red marker is a pre-fusion RSV, and the post fusion on the right, you can see they look entirely different. So the post fusion form had low neutralizing ability when following RSV infection, and they formed immune complexes in the lungs. Now, that was only discovered later, so this is one of the disasters of immunization history. And since the 1960s, they ceased RSV vaccine production until in the recent years, they realized that the pre-fusion form was much safer, and it induces very strong neutralizing response appropriately to the antigenic site. So an important piece of history to know the difference between the old vaccines, which they ceased developing, and the new vaccines. Now, here's a list, a bit of a rundown of all the technologies that are currently used for RSV vaccine candidates. And you can see that they've got the same list as we see with many other vaccines, from live attenuated to the chimerics, the protein-based nucleic acid mRNA, recombinant, and then the monoclonal antibodies. So we've got the usual collection that we have with many others. Now, the two I just want to touch on today, there are two recombinant pre-fusion vaccine, RSV vaccines that are now have got regulatory approval in some European countries and Canada and the States. And there's one monoclonal immunization, like passive immunization, that Emma will refer to. Now, I'm going to briefly touch on these. The first cabs off the rank are vaccines available for adults. There's two I want to highlight today. There's one from GSK, which is an adjuvanted RSV pre-fusion called RSV. Now, this vaccine has got a proprietary adjuvant with it. So the adjuvant helps drive the immune response to the vaccine to enhance T-cell response. Now, the adjuvant is the same adjuvant that we see in Shingrix. So that's the zoster vaccine, and we know how effective Shingrix is. The adjuvant in this one is half the dose of Shingrix. So this vaccine is the one that we're going to see in New Zealand very soon. And the other vaccine that is not that far away is called Abrysvo from Pfizer, and this is a bivalent pre-fusion vaccine. This one contains recombinant pre-fusion proteins. It does not have an adjuvant. And once again, both of these vaccines are focused on adults aged 60 years and over. The safety profile, both of these vaccines have a very similar safety profile. They've been through phase 2 and the large phase 3 studies now. Their reactogenicity tends to be mild. They have a large amount of local reactogenicity, maybe up to 60%, and probably about 1 in 2 people have mild or moderate reactions, including the usual headaches, sore arms, myalgia, what we traditionally see with vaccines. They can be given with the flu vaccine, but you do see increased injection site pain. So the safety warnings in the clinical trials, Abrysvo, the bivalent, did see 2 cases of Guillain-Barré syndrome. Now, we do see these occasionally with vaccines. It's very hard to know if it's just coincidental or association. So these are some important safety signals to continue watching. Now, the pivotal efficacy trials of the phase 3 large studies, that's what the licensure is based on. RSV, this is the adjuvanted vaccine. Here's the summary data for RSV. And what you can see is this vaccine looks like it's very effective, particularly against severe lower respiratory tract infection, with a vaccine efficacy of around 83%. And this is similar, interestingly, in adults over 70 as it is in adults over 60. The phase 3 trial had about 25,000 people in it and was over 17 different countries. So it's a reasonable sized phase 3 trial. Now, these are interim results. This trial has followed people up for around about 6 months. But the results to date are looking good, but there will be further results over time. Now, interestingly, with this study, they did look at giving a second dose a year later. And very interestingly, it didn't appear to provide any extra gained benefit over 1 dose at 2 years. So there's no answer as to whether you should or could boost a few years later. At this stage, it's recommended only a single dose. Now, Abrysvo, which is the non-adjuvanted vaccine, initially they did a young adult challenge study, which is a really interesting study to do, where you actually, the people in the clinical trials are exposed to RSV. And you can see that it was highly effective in the young people at preventing symptomatic or asymptomatic, and more effective against symptomatic, and reducing the peak viral load. So looking good. They then did their pivotal trial, which I believe was in about 35,000 people in adults 60 years and over, once again showing reasonable effectiveness against symptomatic and much higher effectiveness against severe disease. They're both looking pretty similar at the moment in terms of their effectiveness. And again, looking effective in adults over 80 and in people with comorbidities. So good sign. They're both looking like they're going to be very effective vaccines. Now, Abrysvo has also been used in pregnancy. Interestingly, RSV without the adjuvant was trialled in pregnancy, but they stopped the trial because they saw an increase in preterm, which is hard to know if it's associated or not. So Abrezvo is the vaccine that has been licensed in some countries in pregnancy. They've used 2 clinical trials to date. You can see the phase 3 trial had about 7,400 people in it. The only concern about pregnancy at this stage is if or if not, it may be related to an increase in preterm birth. There was a non-statistical difference in the vaccinated versus the placebo. Now, that doesn't mean there's an association. It means there's a caution as to whether there could be a link with the vaccination and preterm birth. Now, from first principles, it was a little unexpected because we don't see this with the RSV virus, but it's definitely worth looking out for. So when the Americans licensed this vaccine, they recommend it to be given from 32 weeks gestation. And when the Europeans approved it, they recommended it from 24 weeks. And that was just because of this theoretical clinical concern. So this is what they've recommended for the vaccine in pregnancy. The purpose of using this vaccine in pregnancy is not really for the pregnant woman, it's to offer passive protection to the infant where severe diseases, and it's looking about 70% effective up to 180 days after birth. So far looking good, but that's not licensed in New Zealand as yet. Now, the one other vaccine that's coming soon is an mRNA vaccine, like we've seen with COVID vaccines. Once again, it's gone through its pivotal randomized controlled trial with about 35,000 people. Vaccine effectiveness is very similar to the other two at this stage. So another potentially very useful RSV vaccine on the way. So what are the international recommendations? Well, the states have recommended both the protein vaccines for use in people 16 years and over. I understand the mRNA vaccine is going to be presented later in the year, and they are also hoping for approval. The Americans recommend the use of a single dose. They noted that clinical trials are still relatively limited, that we don't know how useful this will be for those with immunocompromised. And Emma will discuss the use of the passive immunization. Now, I just left in here a list of underlying medical conditions because I think if we start thinking about the use of this vaccine, as GPs, we're going to need to think about who are those in amongst this clinical group who could benefit from the most. And it's as we would expect, it's very similar to the list for flu. In the UK, they have recommended the passive immunization for neonates and infants, and they have recommended the active vaccination for older adults, and they had suggested starting from age 75 years and older. In New Zealand, how are we doing? Well, hot off the press, RSV has got gazetted last week. So this vaccine, this is the adjuvanted vaccine, will now be available in New Zealand soon on the private market. It'll be available for those 60 years and older. It'll be offered as a single dose. That's some packaging I just pulled off the internet. We're expecting it to be available from around about mid-May. At this stage, it'll only be available through general practice until they get classification for pharmacy use, hopefully later in the year. There have been no decisions about whether this vaccine will or won't be included on the national schedule. And I have asked the company what they think the private market price will be. And at this stage, that's their indicative price of somewhere between $260 to $300 a vaccine. That's to us as the provider, and then we will have to add our service costs onto that. So that's where we are with vaccines. We've got one now available and will be in New Zealand very soon. We've got another one that's looking very good potentially after that, and then an mRNA to follow. So those are the adult end of the market. And then I'm going to stop now and hand over to Emma to talk about the child end of the market. Kia ora.
Kia ora. So I've already been introduced, but I work in Tamaki Makaurau, Auckland, and I work at both Starship at the University of Auckland, and I have a little bit of time as a medical advisor for the Immunisation Advisory Centre too. So I'm going to speak about RSV, and I am a paediatrician, so I have no conflicts to declare nor funding, but I'm very passionate about this virus. So the quick recap, based on what Nikki's already told us, a very common respiratory virus, seasonally spread in winter and early spring, so that by the age of 3 or 2 or 3, almost all children have had RSV, and you can have more than one infection through your lifespan, and certainly although having more than one infection in a season is not so common. But for young children, RSV is the virus, whereas bronchiolitis is the disease that we all know and love and think about during winter. So what is bronchiolitis? It's initially an upper respiratory tract infection with symptoms, and then it's fever plus cough or fast breathing or respiratory effort and wheeze or crackles, or all of those things together. The bronchiolitis is most severe in the first 2 or 3 days of the illness, or so after day 1, day 2, 3, infants will tend to get worse. And I'm really talking about the infant disease, the first year of life. It typically lasts for about a week, but up to 10 days. And you do get a post-bronchiolitic cough that can go on for weeks as well for some infants. And this is just I think, a really good cartoon imagery that we can show. I show to whānau, showing a baby with a really hyper-expanded chest. His airways are edematous and swollen, and there's mucus in there plugging. So that viral-induced inflammation and airway obstruction from the mucus is what causes the narrowing and difficulty breathing for an infant. So for New Zealand bronchiolitis, the infant stats are that 1 in 13 infants will be admitted with this illness. It accounts for half of all of our paediatric admissions for those aged under 1 year in New Zealand in children's hospitals and children's wards. And it's very inequitably the disease burden in that 3 times more Māori infants and more than 3 times more Pacific infants will have admissions compared with non-Māori and Pacific infants. And it's also more children with socioeconomic deprivation are more likely to have admissions than those who don't have deprivation. And I've put down the bottom there these slides of thanks to Libby, who's a fabulous nurse practitioner and research fellow in the Department of Peds, and some of these slides are hers. So what about the burden of RSV for infants and young children in New Zealand? And we know that RSV causes most of the bronchiolitis that we see in our young children. So as Nikki alluded to before, there's been this fabulous Shivers project that's looked at, particularly this data is from the Greater Auckland region, showing about hospitalizations and what's attributable to RSV virus amongst young children. So this is along the bottom is actually 2012, 13, 14. And the top line is showing all acute lower respiratory tract admissions in the Greater Auckland region, surging each winter. And the dark is the laboratory confirmed RSV component. So you can see that for children up to the age of 4, it's at least 40% of our acute respiratory infection as it's the causative agent. And that's a much bigger proportion for the under 1s that RSV. So it's a much bigger burden than influenza for us in paediatrics for causing hospitalizations and admissions in young children. And this, from the same data from the Shivers group and these hospitalizations caused by RSV, you can see that the risk and the incidence the ratios are much higher compared to children aged 2 or 3, but are much higher for infants who are under 3 months, for those that are 3 to 6 months, for those that are 6 to 12 months, and those that are 1 to 2. So that the youngest infants are most likely to have an admission, and most at risk of admission from RSV, and much more likely to be hospitalized compared with older children or toddler age. We also, in the same data, they showed again the significantly higher burden of RSV hospitalization amongst Māori and Pacific children. But when we see that, we really want to do something. Surely we can treat these infants. What about trialing salbutamol? Well, really big, numerous numbers of studies now and systematic reviews show that there's no change in hospitalization, length of stay, feeding, or oxygen if you trial salbutamol in infants or use salbutamol in infants with bronchiolitis under the age of 12 months, including those who've got a history of atopy or a family history of atopy or allergy or asthma. And there are adverse effects if you use salbutamol, so don't use these beta-2 agonists. They only cause more trouble for the infant than help them. And similarly, there's no role for systemic or local nebulized steroids. And I know that you know all of this, but I think it's just a good reminder to let us know that bronchiolitis management, it was really, the care is supportive, which is why we have this hospitalization requirement of these infants. They may need fluids intravenously or nasogastrically, oxygen to keep saturations above 92%, and some younger infants certainly need help if they're having apneic episodes with that. And there's really big evidence now that there's no efficacy from using salbutamol, that's beta-2 agonists, steroids, antibiotics, adrenal nebulizers, or even for us in the at the hospital front line, that use of chest x-rays, blood cultures, blood tests don't actually proactively help us in management of this. It's a very a clinically made clear diagnosis, and the care is supportive. There are certainly risk factors for more severe disease, as we know, being born preterm, being on the younger end of the infant age group, so under 10 weeks, having postnatal exposure to cigarette smoke, or being breastfed for less than 2 months. And then those chronic medical conditions like chronic lung disease or prematurity, having a heart or a neurological condition. And also for Australasian infants, that is being of Indigenous ethnicity, that's Māori Pacific, or Pacific infants born in New Zealand, or Aboriginal Torres Strait Islander infants. And this is all outlined beautifully in a bronchiolitis guideline and referenced in our Starship clinical guidelines as well. So most infants recover from their bronchiolitis, of which RSV is by far the most common cause. A few are critically unwell, some have recurrent wheezing cough, and some may have permanent airway damage. Who experience of which the infants get severe or critical RSV? Well, we really know those premature infants, especially those born earlier than 32 weeks, and those with chronic lung disease, and infants with congenital heart disease. And in context for Aotearoa, we know that Māori women have a greater relative risk of having extremely premature or very premature infants compared with Pākehā European women, and Pacific infants are also overrepresented in those who are born preterm. What about costs? Well, hospitalization for RSV-related bronchiolitis, as was looked at just as an example amongst these parents and caregivers of infants in the States who were preterm when they had RSV. There's the trauma of being transferred to a large treatment centre, and I've got an image there of the Westpac helicopter, which we see coming into Starship. The family whānau impacts of stress, poor health and productivity loss, and the financial and medical concerns that carry on months after discharge when you've been uprooted during a time of an intensive care admission when you have a premature baby that's affected with RSV. But although we talk about preterm infants having a higher risk of the severe and critical RSV, the largest burden and cost and healthcare burden really comes from all our term infants in our health resources, because we looked at, again, this is the same Shivers group looking at Auckland hospitalizations due to RSV amongst all the acute respiratory infection hospitalizations in kids under 5 years. Around 8 to 10% were admitted to intensive care, of which a significant proportion are due to RSV. And of any of those admission hospitalizations, even though the median stay may only be 2 to 3 days, that total cost for the Auckland region each season for RSV direct related costs was 2.6 million, or around 5,000 per admission for otherwise healthy infants. And this slide is care of Professor Cass Burns, who's a paediatric respiratory specialist and as a real expert in chronic lung disease of childhood, in particular in bronchiectasis. But she just listed down there lots of references, but really we know that repeated RSV infections or severe RSV infections, or even your first RSV infection, is part of the milieu that creates these chronic lung diseases of childhood that ultimately may be an infant that has a preschool wheeze, or may precede asthma or bronchiectasis for the more severely affected. And those infants that have chronic lung disease of childhood, like bronchiectasis, are also repeat RSV infections in childhood or early infancy, the same ones who become adults with chronic lung disease, such as bronchiectasis, chronic obstructive pulmonary disease, and asthma. So RSV for tamariki in Aotearoa, New Zealand, it's a really common respiratory viral infection, a leading cause of bronchiolitis, and bronchiolitis itself is a very common cause of healthcare use, hospitalization for infants and for those under the age of 5. It causes critical respiratory disease for us, particularly amongst our high-risk infants, and that's those born premature and with heart and lung conditions. The disproportionate impacts of RSV are seen amongst Māori and Pacific infants and whānau, and the current treatment is essentially supportive. So really we want to think through prevention, which is what we are hopefully going to have my next 10 minutes on. So I've got the very short story of palivizumab here. This is one of the monoclonal antibodies that's been around for some time. You can see there a cartoon image again, a monoclonal antibody, IgG shape, attaching to the fusion, the F protein of the RSV virus, and preventing it from infecting cells. So this is given by intramuscular injection monthly during winter season. That's when classically RSV is a winter virus. And we've had a bit of a mix up with COVID, but now we're most likely back into our winter seasonality. And it's given to the highest risk infants, but it's only lasting a month. So you need around 5 to 6 injections throughout an RSV season to protect an infant. And it's expensive to administer that. So we call it passive immunization. And amongst those highest risk infants who are given that, there's evidence that it reduces hospitalization visits or attendances and reduces intensive care admission rates. And so internationally, it's recommended in high-income countries and used in European countries, US and Australia, amongst very high-risk infants. And it's been licensed in New Zealand since 2016 with MedSafe, yet not funded to a point. And this is just showing briefly a systematic review of the guidelines of which infants should be getting RSV prophylaxis, like palivizumab, if that was available. And you can see a long list of the European countries in this particular review, most giving it to infants who are born at less than 29 weeks of gestation, so as soon as they leave the newborn intensive care into the RSV season. Some giving it to those 29 to 32 weeks, some even giving it to those born less than 35 weeks. Any infants with bronchopulmonary dysplasia, which is chronic lung disease of prematurity, congenital heart disease, or severe combined immune deficiency. So different ticks there indicating which high-risk infants in these countries were enabled to have palivizumab by monthly injection through their first RSV season. And so Nikki showed the large surge of RSV we saw that happened in 2021. And it really did, it was very dramatic and actually crippled our healthcare, paediatric healthcare and services, including intensive care, just filling up beds. And so an urgent application enabled palivizumab to be funded for us from the end of 2021. And this is the list of infants up there to 12 months and their risk, that these were the infants who were able to have palivizumab in 2022 and 2023 as a result of that. You can see, and that really is a very small band-aid on a large problem of RSV infections. And just in the greater Auckland region, we audited how many infants that was in 2022, and it's only 170 infants that fulfill these criteria that were enabled to get palivizumab, but an important protection for these very high-risk infants of critical RSV. However, that funding for palivizumab ended at the end of October, at the end of last year, where they announced there wasn't going to be funding further perpetuated for palivizumab, so that's not available for this RSV season. So what is coming as RSV prevention for infants? Well, Nikki's talked about RSV vaccination, that is the RSV pre-fusion vaccines. And I think most excitedly is long-acting immunoglobulin agents. And there's two that have, one that's licensed, nisivimab, which I'll talk about, and clesrovimab. I haven't quite got my mouth around how to say that one, which is as yet, as far as I know, not approved in any region. And I just bring this particular paper and these images, and you can see not only do we have monoclonal antibodies for children and infants, but in phase 2 and phase 1, so development vaccine, multiple other vaccine, RSV prevention vaccine agents that are still being thought through for children at different ages. So it's a pipeline, and it's a really lovely paper in the Lancet, just going through the things that are available for children that are coming. But I'm only going to talk through these, nisivimab, the long-acting immunoglobulin. So this is nisivimab. It's a monoclonal antibody with an extended half-life and an alteration of the receptor site that's meant that it's able to last longer than palivizumab. And so a single intramuscular dose lasts for an entire RSV season. So that is one injection, which compares to palivizumab, which required monthly injections. So 1 versus 6, which you can immediately see the benefits in that administration and many and acceptability. It's not a particularly large volume, so only 0.5 ml for young preterm or infants leaving maybe our newborn intensive care, and 1 ml for those over 5 kilos. And it's licensed now in the US, FDA, the European Medicines Agency, and Therapeutics Goods Association in Australia. So this is the just some efficacy data from the bigger trials about prevention of RSV, lower respiratory tract infection, through to 150 days. That's nearly 6 months, or almost 5 months. so medically attended RSV, that's not hospitalization, but medically attended, looking at infants who were born over 35 weeks, so they're nearly term gestation, randomized 2-to-1, and efficacy of around 75%. And then similarly at infant, preterm infants born, so between 29 to 35 weeks, with again similar efficacy in preventing medical attendance with RSV, lower respiratory tract infection. And this is these are really exciting data. And then the same study showing this information out with more grilling down on what was prevented, the medically attended RSV, LRTIs, the hospitalization events, and the very severe medically attended, and all of these having good efficacy in the high 70s when the infant was given a single dose of nirsevimab, and that lasted through 5 months, one single dose. And then all-cause lower respiratory tract hospitalization prevention efficacy of 30-40%, which is what you'd expect when we think how much RSV is actually attributing to those lower respiratory tract infection admissions. And so these studies were called the MELODY studies, and then another very large study called Harmony. This is the phase 3 data. Again, infants randomized to receive nirsevimab. This is France, Germany, and another centre. I can't quite see on my screen. But infants at different ages, born either at term, mostly born at term, but some preterm infants at different age groups, but entering their first RSV season. So that is some being given it at the age of 3 to 5 months, and some being given it as older infants, and impressive reduction in hospitalizations due to RSV of 80%, and reduction of very severe RSV-related lower respiratory tract hospitalizations as well. And this was presented at a meeting last year in Europe, and also aided the licensing of this agent. So adverse events, it's a single intramuscular injection. So yes, mild side effects of, for most pain, but when comparing serious adverse events, no differences between placebo and receipt amongst any of the studies, nor even amongst grade 3 adverse events. No difference between placebo, which was intramuscular saline, versus nirsevimab, so showing there's no difference in severe adverse events. So a very safe immunization prophylaxis. So how's this being used? So in winter 2023, so that's the end of the Northern Hemisphere winter, in the US, they were recommending a single dose of nirsevimab. So this is, we're thinking of like an immunization for all infants aged under 8 months that is born into an RSV, their first RSV season. They really, this is a huge change that we're thinking about giving prophylaxis or immunization to all infants for RSV in their first RSV season. And for those with risk factors that I've talked about before, like chronic lung disease, congenital heart disease, but also the Indigenous infants, that's all American Indian and Alaskan Native infants, were able to have a dose of nirsevimab if they were older and having their second RSV season. In the UK, at the moment, it's recommended for all high-risk infants who would have qualified for palivizumab and funded for them in that winter, although they have broader recommendations coming. And just for this winter so far, we've heard Australia, Western Australia are also recommending and funding nirsevimab for all babies born from October 23. That means they'll be 6-7 months into their winter season or younger. And Queensland are also recommending for all infants born from April 2024. So that's all infants going into the RSV season who will be younger. And New South Wales are recommending for all preterm infants as well as all other high-risk categories as well. So any infants born 37 weeks or less. So that's big news in Australia that 3 of their states are funding this very broadly, but not available in other states. So this is, I thought, really cool because it's real-world data from Galicia, which is a little map of Spain. It's a northern region of Spain there. They are giving nirsevimab widely to all newborn infants in their entire region for their winter last year. And they've got some real-time data, and I put the website down there. But what you can see in this, so they've so far immunized up to this week. I just looked at the website yesterday. Nearly 6,000 infants through the season, and they've done catch-up for older infants of 6,000. So they've given 13,000 infants the nirsevimab through their winter, and what this shows you is each of these are cumulative cases of RSV hospitalizations in infants. And these are different year groups. So I have to look at this a bit closer, but 2019, 2022. And what is down here is a cumulative infant hospitalizations for RSV through their winter so far. And you can see that the impact of them has been very marked for them. And just to show you that it's not just an anomaly, that it's not that there's no RSV circulating by chance in this area. This is the older children and their usual RSV-related hospitalizations across different years, and that they didn't receive nirsevimab and they're having a normal RSV season, and subsequent hospitalizations in those older children who are not receiving nirsevimab. So I have lots of questions about this too, and I'm sure you do. And I think, well, what happens in the next year for those infants who had prevention and didn't get their RSV, their first RSV infection as a little baby? They get it as a 2-year-old or a 3-year-old. Nirsevimab has sort of delayed their first. Will it be much more severe? And so this was a really interesting paper that's just come out last month, showing that infants who, from the Melody study, so were followed into their second RSV season. So we've got data now that are now 360 to 500 days after their first single dose of nirsevimab that prevented their infection, or may have prevented their infection in their first season of RSV. That looked at those nearly 2,000 infants, nearly 1,000 who received placebo. And when they did get RSV as 2-year-olds, there was no increase in the group of infants who had nirsevimab. They didn't have an increased medically attended RSV infection rate, and they didn't have any evidence of antibody-dependent enhancement. That is, did they get worse or more severe disease when they got it in a delayed way because they've had some antibody prior as their immunization or prophylaxis? So I think this is really important too. And what about in the luxury situation where we might have both maternal vaccines available, which Nikki has talked about? So we could be immunizing women in pregnancy, and we had nirsevimab to also give infant prophylaxis, passive immunization. Which would you use? So in the US, they do have both products available, and as Nikki showed, that these are both safe and effective in preventing lower respiratory tract infections from RSV for their infants up to about 5 to 6 months. And you don't need to give both, obviously, for most infants. If they're born 14 days after maternal vaccination, so if a woman receives the vaccine in pregnancy, obviously the infant doesn't need to have passive immunization. And they're advising to give information for women on both options, and that be a choice. And just showing this statement from the American College of Obstetricians, unequivocally supporting the recommendation of pregnancy vaccination in pregnancy. And I thought this table, which I tried to mash together a couple of different tables of advantages and disadvantages from different sites, but the advantages of active vaccination of women in pregnancy is that there's instant protection from birth. They provide a polyclonal type antibody response. They may be less likely to cause to lose effectiveness in the future with vaccination if there's any mutations in the F protein in the virus. They're likely to be cheaper to produce than monoclonal antibodies. Whereas, however, that sometimes the reduction may not be, the protection may not be as good. If a woman's immunocompromised, for example, she won't produce as good a response against the vaccine, or if the infant's born within 2 weeks of vaccination, there's obviously this potential small risk still to be sort of established if there's really a risk of preterm birth. And it's not protective for any infants who are born premature, obviously. They can't active vaccination women in pregnancy won't protect our preterm infants. In contrast, monoclonal antibodies, the antibody levels may be slightly slower to wane than protection from the maternally derived RSV vaccines. That's definitely a plus. It's a direct receipt of antibodies, so you don't rely on transplacental transfer and the issues around women in pregnancy who might not be immune competent. There's no risk for adverse pregnancy outcome. Definitely, and the disadvantage has been this massive limited availability and really severe supply issues with nirsevimab after such broad recommendations in the US, and such that there was very little nirsevimab left for many infants in the US. And it does require the baby to have an injection as opposed to the woman. So RSV in Tamariki and Aotearoa is a common respiratory viral infection, very common cause, all those things I've said before. We really need nirsevimab right now for our winter, for all, I would say, with our burden of disease being around 6 times what the US see with RSV. But at the very least, we need it for our highest risk infants who now will not be getting palivizumab. The maternal vaccine is really not far away, as Nikki's talked about. We have this license for for older people. Maternal vaccine for RSV will be a game changer. And nirsevimab, we need both of these things, but both strategies are needed to work in combination. But right now, nirsevimab is what we need because it's licensed in numerous places.
That was an awesome talk. Very interesting. Good to hear what's happened and what's happening, what's on the horizon soon. So Emma, especially that Spanish data, that was amazing. Is there anything on the horizon now in terms of bringing back that nirsevimab? I mean, it sounds incredibly cost saving, doesn't it, with the amount of hospitalizations it would prevent?
Yes, and I feel like I say I have no conflicts, but I have recently been on the radio kind of berating the fact we don't have this. At the moment, it's not licensed as far as I know by MedSafe, and that is actually, it's a problem. We need that first of all, and then we need it to be funded. But like I say, having palivizumab for the last couple of years has been, for a very small number of infants, a tiny band-aid that's really important to keep our intensive care from being overwhelmed by critical RSV. But I'm really worried about the fact we won't have that for this coming up winter. And in fact, there's this fabulous long-acting monoclonal antibody that's been given broadly, in like I say, Galicia and Spain. That was amazing data. But the US advising it for every infant their first RSV season, the whole of Western Australia, the whole of Queensland. I feel quite sad that New Zealand infants haven't got this opportunity. What about you, Nikki?
I feel very frustrated. My own daughter lives in the States, and my granddaughter, who's super healthy, got nirsevimab. And I was very frustrated because we can't get it for the high needs children here, and that's inequitable and tough. And I think the infant immunisation was probably a better bet than the pregnancy. We're struggling to get pregnancy vaccination for Tdap and for flu. And so I think trying to get another pregnancy vaccination into a crowded schedule will be hugely challenging. So I'm a strong voter for nirsevimab, and we should have it now. And it's a huge disease with an enormous burden of disease, and I think it's inexcusable that we haven't got it. So frustrating, being a small country at the bottom of the world with a limited Pharmac budget, which vaccines are falling within at the moment. So I'm keen for advocacy on this one in any way we can.
Okay, awesome. How does the rates of RSV in New Zealand compared to other countries?
The same pattern as everywhere else. We're better at looking for it than many countries. So we've got the amazing Shivers data, which gives us a much better look into it. So the Shivers data gives us the privilege of looking into acute respiratory illness across the Auckland hospitals in particular in quite a thorough way. So our incidence is probably higher than many other countries because of that. But the patterns are the same. Wherever you look in the world, this bug is everywhere, and very similar patterns. Do you want to add anything, Emma?
Well, we do read a bit, as you say, our data's perhaps better because we've been able to have that good level of surveillance. But I think we have probably higher RSV hospitalisation rates recorded in certain areas, particularly the Greater Auckland region as well. And we do know we have some of the highest rates of bronchiectasis in the world. And there is a real interest, and that's that established suppurative lung disease, there's a real interest in whether it's some of our repeated, perhaps more severe RSV type infections or other viral infections in combination that lead to that as well.
I think to add for the elderly too, that RSV hasn't been looked in most countries at in the elderly. And the more you look, the more you find in the elderly. So the burden of RSV, particularly in frail elderly and very elderly, a bit like what we've seen in COVID, is probably a lot higher than people realised. So I think particularly in the elderly end of the market, we're going to see better projections of RSV rates. The other thing is, of course, like flu, what we don't account for is you get the viral illness and then later on you get your heart attack or your respiratory flare up or your stroke. So that I think that's also not been accounted for. So I suspect we're currently underestimating the burden of RSV in elderly, and particularly for our elderly. And once again, particularly for high-risk vulnerable populations like Māori Pacific, I'm sure the rates are higher than we're accounting for.
With the MABs that are approved, are any of them able to be self-funded in New Zealand?
That's a great question. So nirsevimab is not licensed, so I would say no at the moment. I'm also really concerned about the availability of nirsevimab when we see that entire states, and I'm not concerned, I mean, it's fabulous for Western Australia, but that as the rest of Australian states are as well, about the equity around accessing that anywhere in the Southern Hemisphere when there's widespread use in some areas and not in other areas. So I would say certainly not in New Zealand at the moment for nirsevimab. And palivizumab used to be able to be privately purchased and given, and there was a few parents, literally a few of very extreme premature infants that did do that, several hundred per dose times 6. And I don't know what will happen with that now, but I would imagine that should be still available. Tricky to administer. We used to have to, they'd come in for individualized appointment or managed through primary care if they could to get those as single line doses.
Should we routinely swab babies for RSV with respiratory illnesses in primary care?
No, we don't. The study where I took the quotes from, we were doing a research study where we're using a rat test. Like we've got so used to rats now from COVID that we used a trial with rat tests, which looked at COVID, RSV, and flu A and flu B. And you can do it with kids and adults. And the advantage, one of the advantages post-COVID is these rat tests are much more sensitive and specific than they used to be. So there is the potential to use rat tests. It's hard, as we know, to swab young kids, but it certainly changes people's attitudes and knowledge when you swab and get a result on the spot. And now that we've got better rat tests, I personally think that would be a very positive way to go. I mean, not, as Emma pointed out, that you can treat it with an antibiotic or an antiviral, but once you know what it is, you can manage it appropriately to the condition it is, and people change their behaviour because of it. So I think it is important to consider point-of-care testing as we go forward.
And are those point-of-care tests, Nikki, going to be more widely available, or was it just within the context of the research?
I hope so. We purchased them for a research study, so at this stage they're not widely available, but I mean, we're hoping that if we get the message out there wider, there will be companies that'll be interested in coming in and selling them within the New Zealand context. Certainly, we learned a lot from COVID, so I think, point-of-care testing has come such a long way, and knowing now that it makes a difference to our behaviour and our response. And, I think it'll help with non-pharmaceutical intervention. So if you know you've got RSV, you'll behave differently in your household. You'll behave differently about going to work. You'll behave differently with your children in your early childcare centres. So I think there's a lot of gains from considering it, but as yet it's not available on the private market. No reason why it can't be, though.
I think that would be amazing. It'd be a game changer in primary care.
I reckon.
Yeah. With regards to the maternal vaccinations and the immunoglobulins, have there been any modelling studies that show potential cost savings here in New Zealand or Australia with that?
Yeah, they have. And Pharmac have got them, and they have. And they certainly come out quite well. But once again, this is a Pharmac decision, and they have to line them up against all their other health needs in Pharmac. So, we've got a smaller budget than many other Western countries. I think that's the problem. I think, the cost analysis data is there and it's quite clear. Emma, do you want to add anything else to that?
I was just going to type in the chat that there is actually, obviously, Nikki, you've done incredible collaborative work with someone called Nam Prasad, PRASAD, who has done a modelling study comparing them and the cost effectiveness in New Zealand. And, the monoclonal comes out on top, but both of them are going to be cost saving for sure.
I vote for the monoclonal because I also think we don't allow for the challenge of the delivery mechanisms in pregnancy. And I think the monoclonal is actually slightly more effective by the look of the data today. But, whatever we can get, we need.
Has there been any research looking into combining the RSV with, say, flu vaccine or anything like that?
Yeah, in kids or in adults. Certainly in adults, flu and COVID vaccines, we're pretty keen to get combined. And I can imagine in a future universe to also combine RSV with flu and COVID. I think in the elderly, it's beginning more and more like they'll be the big three, the flu, COVID, and RSV. So as yet, no, because we're just getting the RSV vaccines now. But you can see the technology is pretty similar to what we've learned with COVID. So I don't think it's a long stretch to say, yeah, we'd expect it to be coming in the next few years in the adult end, different in the childhood end, of course. We haven't yet cracked flu vaccines for kids under 6 months. I doubt if we can combine pregnancy vaccinations. I guess it's always possible. Any thoughts, Emma?
And yeah, we just need something. It really is a burden of disease for sure.
Personally, I want better delivery mechanisms so you don't have to stick needles into everybody all the time. And that's coming as well. And it frustrates me that the world doesn't do that faster. I think we'll get much better uptake if we can move much faster towards, MAC patches, intradermal. But we'll get there eventually. We're just slower than we should be.
Oh, thank you, Nikki. In an adult with an RSV infection, are there any clinical features that might differentiate that from other winter viruses, or no?
Not that I'm aware of. I don't think it's not nearly as obvious as kids. I think it just appears as a respiratory illness. You've got a large burden of mild symptomatic disease, and I suspect if we looked harder, there'd probably be a lot of asymptomatic too. It's even like flu. I defy someone to be able to tell me that they can clinically tell flu from non-flu. So what we know is older people get RSV more severely than many other respiratory viruses, but then lots of people don't. So good luck to us figuring that out.
Well, I think that's most of our questions for tonight. Thank you so much, Emma and Nikki, for joining us. It's been awesome, and hopefully the Q&A has been informative to our audience. So have a good evening, everyone. Thank you.
Kia ora. Thanks all.